Okay, so we're looking at epidemiological study designs. I'm trying to see if we can make sense of what they are and how we use them in epidemiology. You remember the definition of epidemiology, a study of the distribution and determinants of health-related states and events in human populations, and the application of this to this solving of health problems. And I said that epidemiology will have two broad categories, descriptive and analytical epidemiology. So we were going to be looking at study designs in that perspective. Pardon me, let me show you, I'll stop this and let me show you a diagram, and then I'll come and talk based on these slides here. So let me share something else with you. Apologize if it isn't very legible, but I just wanted you to have an overall view of epidemiological designs to see how they are broken down and arranged. And if you can draw this diagram, and you can explain it to a reasonable degree, I don't think there's anything that I personally will ask you around study designs that will deviate too much from how this diagram looks and some explanation of some of the concepts there. So epidemiological designs are largely divided into two categories. So what is an epidemiological design? So for you to be able to identify distribution and determinants of health-related states or events, you must carry out some form of study. Somebody was asking me the difference between survey and surveillance. You must carry out some form of study. You must find out, you must ask those questions: who, what, who, when, where, how, and why. You must ask those questions, and you need a design, an epidemiological design, which is a systematic method by which you are going to craft objectives and collect information to be able to respond to those objectives. Be able to find answers to the questions that you are asking for you to be able to do the interventions that you need to do in epidemiology and respond adequately. So epidemiological study designs are divided into two broad categories, as agreed by most epidemiologists. Category 1 is observational, while category 2 is experimental. Two broad categories, so you must understand that every other type of research design you're going to call is either under the broad category of observational or under the broad category of experimental. And observational is simply that, to observe. Because I'm going to be on this slide for a long time, so nobody should send me a message saying slide is not changing, slide is not moving. I'm not going anywhere anytime soon. For the next maybe 15, 20 minutes, we'll be here. Because I want you to keep looking at this while I explain. Then I will give you the slides that I was showing before now, so that you could go read up and reinforce your learning. But if you pay attention to me and maybe watch me look at the slides a little later, it should stick. So observational epidemiology and experimental. These just follow the meaning of the word. Observational means to observe. Experimental means to intervene, to experiment, to dabble, to tinker. So in observational, you are not doing anything else but observing what is going on. In experimental, you are making some changes and seeing how those changes are being received or accepted between one group and the other. But in observational, you are just merely watching what's happening. You're not getting involved. You're not doing an intervention. You're not creating any changes. Observation. Under observational design, we have two other subcategories. So experimental, observational. Under observational, we have two categories. Descriptive, or some people call exploratory. I prefer the use of the word descriptive. Exploratory is usually used in some other sciences. We don't use exploratory so much in epidemiology and in public health science. We use descriptive. While the other broad subcategory under observational is analytical. So your observational study is either descriptive or analytical. And descriptive follows the descriptive epidemiology, in which the questions to be answered are, what are the questions, quiz time, what are the questions to be answered? What are the questions to be answered under descriptive epidemiology? Please type them. What are the questions to be answered under descriptive epidemiology? If you are in class, type them in. Thank you. Okay, so the epidemiological questions that are relevant, for descriptive epidemiology are what? Who? Where? And when? Those are the four questions. How and why are more suited for analytical epidemiology? So let's look at the study designs under descriptive epidemiology. When you have in mind what descriptive epidemiology seeks to achieve, is to describe the characteristics of the disease or the health-related state or event according to the case definition, what, according to the frequency of occurrence of that case, according to time, person, and place characteristics. That's all it's trying to do. And there are different kinds of study designs that can help you achieve that. So the specific study designs under descriptive are case reports. If you are a doctor or a nurse in this class, you know what case report means. Case report is a particular person who has a disease or who has a health problem. You are reporting that particular person, that particular issue. You're reporting it. You're reporting it. When we were medical students, we'll be told to clerk and come and give to do a case, maybe a case report as a house officer before the rest of your senior colleagues come and expound on the case. And you say, I'm presenting XYZ male, da da da. So you give the demographic characteristics, you give the demographic characteristics, you give how the disease started, when it started, how it presented, what was the treatment plan, how was it diagnosed, blah 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 blah. You basically, that's a case report. When you have a number of reports like that, a number of cases that you are reporting, it is a case series. Okay, so so we're talking about case series. When you have a couple of reports like that, more than one, and you're looking at the distribution of that particular, so you want to know some particular information about a number of people with the same disease outcome. That's a case series. A case series is a study among multiple persons who have the same or similar disease. So if you are doing treatment outcomes for persons on the treatment for the directly observed therapy short course for drug-sensitive tuberculosis in the University of Port Harcourt Teaching Hospital, it's a case series. Why? Everybody you are studying has tuberculosis, is on treatment for tuberculosis, is receiving directly observed treatment, short course treatment for TB. I'll tell you how that is different from a cross-sectional study. The next one that we're going to look at under descriptive is cross-sectional study. You've heard this before. Cross-sectional study is research done among a sample of the population with information collected at a particular point in time. And you are collecting information from people who may or may not have the outcome you are interested in. Assuming it's a disease, you do not know those who, at the time you're starting the study, you do not know those who have it, you don't know those who don't have it. But one of the things you want to find out is you want to find out who has it, who doesn't have it. It's likely to be one of the things you want to find out. So a population, you collect a sample is a subset, you collect a sample of that population, you apply a tool to it and to the sample to collect information from them. And among other things, you are trying to identify those who have the disease or the outcome of interest and those who do not have. Now you see how this is different from case series, because in case series, you know everybody has it. Everybody has HIV, everybody has TB. That is why they are called cases, case series. It's different from a cross-sectional study. Cross-sectional study, for example, knowledge, attitude, and practice of exclusive breastfeeding among women attending immunization clinics in University of Port Harcourt Teaching Hospital. Now that's a cross-sectional study, because you want to know those who have, what's the knowledge of exclusive breastfeeding? What's their attitude towards it? And how many women, what's the proportion of women who actually exclusively breastfeed? At the time you're starting the study, you do not know who does and who doesn't. You don't know who has good knowledge, who doesn't have good knowledge. You don't know who breastfeeds, you don't know who doesn't breastfeed. You don't know who has a good attitude, you don't know who has a bad attitude. That's the whole study is supposed to find out. The other thing about a cross-sectional study is that you take it at a particular point in time, and you take what is going on at that point in time. If you come at another point in time and repeat the study, your findings may be slightly different because things change from one particular point in time to another. So for example, you come to the immunization clinic to collect your data on a particular day. Even if you do probability sampling methods, You will not see the exact same people you will see if you come on a Wednesday, or if you come on a Tuesday, or if you come on a Thursday. The people will differ. And so it's just like taking a picture. That's why they call it snapshots of the population. It's just like taking a picture at a particular point in time. The cameraman comes, takes the picture, everybody shouts, picture time, everybody's cheese, takes a picture. Somebody's eyes half open, another person's eyes closed, another person still trying to rearrange her hair while the picture is going on, and the camera just picks it. Take it again, take it again, take it again. People rearrange themselves to have their best pose. The camera takes it. One picture has very strong similarities to the other, but there are differences because it's taken at different points in time. So that is cross-sectional study. Relational or ecological is talking about a study of large population groups rather than individuals in the population. Remember, case report is somebody that has the disease. Case series are people that have the disease that you are studying. Cross-sectional study are people in the community or whatever, in a particular group, who may or may not have the disease that you are interested in studying. Correlational are population groups, not individuals, countries, communities that you are studying for a particular characteristic. I hope that's clear. All right. So I will pause and take questions concerning descriptive or descriptive studies before we go and talk about analytical. I'll actually take questions. So if you have a question on descriptive, please don't ask me yet about analytical. Don't ask me yet about experimental. Maybe I would answer your question by the time we are taking those aspects. But let me take questions on these ones so far. Okay, for the sake of variety, you have a question, take your hand up. Or type it in the chat box, wherever you prefer. Go ahead, Usman.
Good evening, man. Thank you for the lecture so far. I want you to throw more light on the cross-sectional. In this aspect of cross-sectional, are you going to sample them randomly, or how will you be able to know those that has it and those that doesn't have this disease that you want to survey?
Thank you, Usman. So you used a word that I don't like. I don't like because many people don't know what to do with that word. How it probably said, are you going to sample them randomly? I have no idea what you mean. Do you mean come into the room where the women are and just share the questionnaire anyhow you like? Is that what you mean? Or are you talking about a probability sampling method, like simple random sampling, in which you will have a sampling frame, which is a list of everybody in the population, and you would use a probability method, like either a toss of a dice or picking from ballot papers or table of random numbers to decide who gets into your study or not? That's a different conversation. Don't worry, don't bother about that. It's just that whenever I hear sample them randomly, my brain starts to scratch because I don't know what you're talking about. But I understand what you are trying to say, to ask whether, how are you going to know those who have it and those who don't have it? That's the whole purpose of the study. The whole purpose of the study is that you're going to produce a tool that will help you identify those who have and those who have not. And you're going to administer that tool to a sample of the population. How you choose the sample is by probability or non-probability methods. That's a completely different conversation for another topic, another day. How you choose the sample. And then you would share that tool. They would respond to the tool, you will collect it, you will go and analyze it. And at the end of the day, based on the responses to the questions in the tool, you'll be able to answer your objective to say, what is the prevalence of exclusive breastfeeding, prevalence of mothers who practice exclusive breastfeeding, for example, because you would have asked a question, did you exclusively breastfeed your last baby? Yes, no. And then the number of yeses over the total population in the study will give you your prevalence of exclusive breastfeeding. That's how you know. And that's the whole purpose of the study. At least one of it. Okay. Ajibola Alabi. Ajibola Alabi, you may unmute and ask your question.
Okay, thank you. Thank you, Dr. Maduka, for today's lecture. My question has to do with the cross-sectional study. In your explanation, you've told us that it's like a snapshot. So it's like a point in time. But what if you collect your samples for over 6 months? You collect your samples over a 6-month period. Is it still cross-sectional?
No, it is not. It is now longitudinal. Cross-sectional, a point in time. Longitudinal, over a period of time. Let me maybe I answer too quickly. Ajibola, are you collecting the same information from the same people at various intervals? Or are you collecting information from different groups of people in that same population? Let me tell you the difference. If my sample size, for example, is 600 HIV patients, and I'm looking at a study that is measuring the adherence to HIV treatment, and I've calculated a sample size of 600 HIV patients, and I know that on the average, 60 patients come to the clinic on any particular day, which means that Monday to Friday, I'll have about 300, and then Monday to Friday the next week, I'll have another 300, making up 600. I don't want to study all of them. I want to study, let's assume I want to study 50% of them on any given day, half of them. It will take me, quick math, it will take me about 1 month of coming to the HIV clinic every day, administering that questionnaire to be able to get to my sample size of 600. Are you following me, Ajibola, so far?
Yes, I am.
Very good. In that case, it is a cross-sectional study. Why? You are coming at a particular point in time and collecting information from the people that are there, and you are just making that up for your sample size. You're making that up for your sample size. Until your sample size is reached, it is cross-sectional. As long as you will not have another encounter with those exact same group of people, because for every clinic is a different set of people. For every clinic is a different set of people. You cannot just do 600 in a particular day. So it's going to take you 1 month, for example, or 3 months or whatever to get that 600. It's cross-sectional. Don't be mistaken.
Okay.
Now, where it is longitudinal is if I have, for example, I'm looking at an intervention or something that improves adherence. So I have a set of 100 clients whom I have selected, whom I see every month for 6 months. So I recruit them into the study and I tell them every month for 6 months, you will come on a specific day, you will see me. I'll ask you about your drugs for the last 1 month. I'll ask you whether you were taking your drugs. I may even take some measurements from you and blah, 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 blah. At the end of the day, I take your viral load or your CD4 and so on and so forth. That is longitudinal because the same set of people, I'm doing repeated measurements. I'm giving that questionnaire over and over and over again to see whether there's any change in trend of these people. That is not cross-sectional anymore. That is longitudinal. And that there's a specific name given to that type of longitudinal study. It's called prospective, over a period of time going forward. As against retrospective, over a period of time going backwards. For example, like I decided I don't want to talk to people, I want to look at their case notes. So I go to the clinic and I look at case notes every visit for a set of, maybe get a set of 100 case notes. I look at every visit for the past 3 months and see what they complained about. That is a retrospective study. And I will tell you because it's not in this graph or in this diagram. So I guess that is why it will be a bit of a confusion for you. But please remind me
And the
before we end
longitudinal
today.
one too is not there too.
Longitudinal is either prospective or retrospective. It's not here, and I will explain to you why it is not here. But please remind me before we end today, and I'll let you know why it's not here. But I hope my explanation suffices. All right.
Yes,
So
very, very well explained. Thank you.
all right, Gloria. Gloria, please ask a question.
Good evening, ma.
Good evening, Gloria.
Thank you very much, ma. Please, I just want you to throw explanation on that correlation and ecological again, please. Thank you.
Okay, it's the same thing. Correlational ecological is population groups. So you're looking at, for example, you're looking at accident patterns in or prevalence of accidents in Nigeria, prevalence of accidents compared between Nigeria and United States. So if you're looking at that, so if you're looking at prevalence patterns of countries in the world, you're not looking at prevalence patterns of accidents in countries in the world. You're not looking at individual accidents. You're looking at there's an overall measurement of accidents to say that the accident rate in Nigeria is this high. The accident rate in, so your study subjects are the countries or the states or the population groups. A typical example is when NCDC compares COVID reporting rates across different states in Nigeria and tells you the state that has the best reporting is Lagos State, followed by Rivers State, followed by Abuja, followed by FCT. States with the worst reporting are XYZ, XYZ. Now, for them to get there, they did an aggregate of all the different things that the state has been doing, but they are measuring state performance, not individuals. Are you following? So that is what correlational study does, or ecological study. All right. So a couple of people have asked that in the chat. A case report is one particular person that has a disease or outcome of interest, and you are describing the characteristics, epidemiological characteristics of that one person. All right. A case series is when you are reporting the epidemiological characteristics, describing the epidemiological characteristics of whatever it is that you want to describe of a group of people that have the same outcome or the same disease. It's different from a cross-sectional study. If everybody in your study population is HIV positive and you are doing something about maybe adherence among HIV, you're looking at the adherence, prevalence of adherence and all of that. Yes, so it's what your objective is measuring is prevalence of adherence. Even though all of them are HIV positive, some are adherent and some are not. So what you are measuring is what helps you to decide whether it is a case series or a cross-sectional study. It's based on your objectives. Now, if, however, I'm looking at the CD4 pattern or viral load pattern of persons receiving HIV treatment in treatment facilities, I can argue that that is a case series because they all have CD4 pattern. They all have viral load pattern. I just want to know what it is, and they are all HIV positive. So if I'm looking at, for example, treatment outcome among persons who are on treatment for tuberculosis. So treatment outcome is either what do they call it now? Converted or treatment completed or dead or transferred out. Or, there are some treatment outcomes like that, standardized treatment outcomes. And I don't want to describe it based on those treatment outcomes. It's a case series. I know it sounds like a bit of difficult, but the more you use it, the more you will get adapted to it. Let's see if there are more questions. Very brilliant question, Melbourne Peters, and this is one of the reasons why I said I did not describe longitudinal studies, and I didn't put it in the stuff in the diagram, and I will explain when I'm talking about analytical studies. Somebody's asking how is longitudinal different from a core study? I'll explain. What's the minimum sample size for a case series? And what's the time frame for a cross-sectional? What's the time frame for a snapshot? No, there's no time frame. There's no time frame for a short snapshot. If it takes you 1 year to collect the data, as long as you're collecting data from different population groups, from different samples in the population, you're trying to make up your sample size, go ahead and collect your data. But once you start taking repeated measurements, you're no longer doing cross-sectional. Sample size for case series. There is no ideal sample size, minimum sample size for case series or for cross-sectional. There is a sample size calculation, a formula that you will use to know what your minimum sample size is. What your minimum sample size is. But if you're asking whether you can put 3 or 4 cases together and say it's a case series, not for epidemiology, it's too small. You can't do that. But what will be acceptable? You need to use a formula to calculate that. Okay, let's allow Ogude ask questions, and we'll have to move very quickly so that we can finish this today. Yes, Ogude.
Hello, good evening, ma.
Yes, please go ahead to your question. Don't bother thanking me. I'm feeling very happy with myself. I've been thanked well enough. Question, please.
Okay. For I'll please, sorry for taking you back. For the cross-sectional studies, if you want to get you said for a sample of a population, take a sample from a population and you collect information based on people that have and people that don't have. That means if you are taking a sample for people that have HIV/AIDS and you are going there maybe weekly to take the collect your information from your samples, that means it has to be different individuals, right? It will not be the same, different individuals that have HIV.
Yes, ma'am.
Okay, thank you.
If your question has been asked and answered, there's no need to ask it again. Okay, last question for this particular section. Let's see. Also, Alabi, you've asked before, but if it's a new question, type it into the chat box. Also, Norma, please go ahead.
Okay, good evening, ma. Good evening.
Go ahead, please.
Yeah, okay, my question is a bit similar to what Karen just asked, but then I still want to ask, in a case where you have people, you're getting HIV, you're getting samples from HIV positive patients, and then you want to compare their viral load in response to a particular regimen that they are on. Let's say it's retrospective, right? And you're collecting it from different people because depending on how adherent they have been, their viral load can either go down or go up. So you have different people coming into your sample and people leaving. So will you say that's a cross-sectional study, even though it's going to be more than a year? Even like if you're going to be collecting those samples from these patients for, let's say, 2 years or 3, will you say it's a cross-sectional study or a longitudinal study?
Okay, so I won't answer that question. I will take the next subtopic, which is analytical study designs, and I will ask you whether that question has been answered at the end of it. So let's do it that way and see whether that helps. But if you still don't feel clarified, then we can go ahead. Some of the questions that we're asking now could actually be answered, I hope, when we talk about an analytical study design. So an analytical study design, basically at its core, is a design that requires us to answer the epidemiological question of how and why without manipulating the study participants. Manipulating means there is no intervention. That's without manipulating means you don't have any intervention. There's no experiment you are giving. For example, if you're doing, if you want to know if smoking is a risk factor for cancer, if there is an association, remember, analytically, you started asking yourself how and why. If there is an association between smoking and lung cancer, if smoking is a necessary cause or a sufficient cause, whatever, for lung cancer. If you are asking yourself that question, there are two major ways you can approach to answer the question. You can either say this group of people take cigarettes and smoke it very well, and you enforce their smoking. And then this other group of people don't smoke, and then you watch to see who develops lung cancer or not. You can't do that today. You'll be arrested, you'll be thrown in jail. But what you can do is people who have decided of their own free will to smoke, you can recruit them, and then recruit people who have decided they will never smoke a cigarette in their life. You can recruit them and encourage them to continue their lifestyle choice and watch out for the outcome. So in an analytical study, you are still observing, but your observation is on the level of trying to deduce risk factors or associated factors through comparison. Where does this whole talk about longitudinal, prospective, and retrospective come in? In identifying the relationship between risk factors and outcomes of interest, you would often, not in all cases, but you would often need to observe people for a period of time. It is impossible to, in many cases, to say that cigarette smoking is a risk factor for lung cancer if you are in no way whatsoever are able to observe or identify a temporal time-based relationship between the risk factor and the outcome of interest. You cannot pick people who smoke cigarettes and then happen to have lung cancer and now say, oh yeah, now cigarette is here, lung cancer is here. It means cigarette smoking causes or is a risk factor for lung cancer. We don't know whether it's an incidental finding. So time must pass. Time must pass for you to be able to make those calls. This is why one of the major ways of data collection for analytical study, not all of them, and I'll tell you the difference. For analytical study is a longitudinal approach or a longitudinal approach, either a prospective approach or a retrospective approach. When I'm talking about the different study designs, you will see which one is the prospective, you see which one is retrospective. So some people differ, but I don't like to look at longitudinal and longitudinal as or cross-sectional as a design as much as I like to look at it as a way of a philosophy behind data collection. How are you collecting this information? Are you collecting information from the same people over a period of time? Or are you collecting information at a particular point in time? That is what makes it either a cross-sectional or a longitudinal study. Now, notice that a cross-sectional study is not only, and if you ask me, it's actually an unfortunate use of that word, because I would probably not be using the word cross-sectional if I was the one that designed this name and had the opportunity to be the one to name it. Because cross-sectional just throws light on how the time period in which you collected the information. But there's more to that than cross-sectional design. Remember I said cross-sectional design under descriptive looks at a population group in which some people have the outcome of interest and some people do not have. So it's a mixed group. You do not know who has and who doesn't have. And you're collecting information to identify, among other things, who has and who doesn't have. Remember, that's what I said. So don't just look at cross-sectional study as a cross-sectional data collection. And don't just look at case control or cohort as a prospective or retrospective data collection. There is more to it than that. The data collection method and mode and philosophy is different from the objective of the study in a broad sense. I hope I've not confused you. But some of these things, I have colleagues who may not agree with me, but this is the way I understand it, and this is the way it makes sense to me, and this is why I'm explaining it to you like this. So give me 5 minutes to take a bathroom break, and then we'll come back. I will talk about analytical cross-sectional, analytical case control, and analytical Okay, so we're back. I was going to get into describing analytical study designs. So there is analytical cross-sectional, much as there is descriptive cross-sectional. Another word that you may be more familiar with for analytical cross-sectional is what some of us call comparative study. Comparative study. Which brings me to one of the distinguishing features, and there are a couple, but one of the major distinguishing features of analytical study design is that there is always comparison. For that to be comparison, you must deal with two or more population groups. You must deal with two or more population groups. I don't know if I'm audible. I think I am. Yes, I am. You must deal with two or more population groups for you to say there is a comparison going on. So analytical cross-sectional study is when you collect information from two population groups at a particular point in time, because you want to see the influence of a particular or a characteristic or characteristics on an outcome of interest. I'll give you a typical example. Where I've seen this most often used is rural-urban comparison. So utilization of maternal, neonatal, and child health services in River State, a rural-urban comparison. Outcome of interest is utilization of MNCH services, antenatal, immunization, and so on and so forth. Delivery under a skilled birth attendant, all those are maternal, neonatal, and child health services. And you're comparing the utilization of MNCH services in people who live in an urban environment and those who live in a rural setting. What you are trying to do is to see the influence of residents, urban or rural, on utilization of MNCH services. That's what you're interested in. So are those who live in the urban area more or less likely to use MNCH services compared to those who live in the rural area? That is an analytical cross-sectional study. So you always call the big name first, the bigger head. Like you say, descriptive cross-sectional. You say analytical cross-sectional. So descriptive cross-sectional, particular point in time, one population group that has both the risk factor and the outcome of interest, and you're just studying and describing how that plays out in terms of answering the first four epidemiological questions. Analytical study is you're looking at, analytical cross-sectional is that you're looking at two population groups. The difference between the two groups is a particular characteristic that you're interested in seeing its influence on your outcome of interest. You do that by comparing the quote prevalence, occurrence, and some other factors in one group as compared to the other group. So analytical study must have more than one population group. Must have more than one population group. If not, it is not an analytical study. And once you have more than one population group, it is no longer a descriptive study, it is now an analytical study. So I hope I've been able to explain the difference between descriptive cross-sectional and analytical cross-sectional. Let's move on to case control. I prefer to say cohort first before talking about case control. It's easier to explain cohort, and people understand case control better when you've explained cohort. So a cohort study. A cohort study is a study that is designed to see the association between a risk factor and an outcome of interest by classifying or recruiting people into two groups, recruiting study participants into two groups. groups are called cohorts. Cohort 1 are persons, people are selected into cohorts. People are selected into cohorts based on the presence or absence of the risk factor of interest. People are selected into cohorts based on the presence or absence of the risk factor of interest in a cohort study. We're getting to 7 o'clock, but I will continue to push because I think it's important we understand this. And so apologies to those of you who have other appointments by 7. I'll keep going until we're done with epidemiological designs, and we'll call it a day. So that's why I'm taking apologies in advance. So if I see people dropping off, I know it's because they have something better to do, and I apologize for that. Cohorts. People are selected into cohorts based on the presence or absence of the risk factor of interest. Back to our example of cigarette smoking and lung cancer. If you're going to do a cohort study to see the association between cigarette smoking and lung cancer, you will select people into 2 groups. Please type in the chat box what those 2 groups would be. Cohort 1 will be people that have XYZ. Cohort 2 will be people that do not have or do not do XYZ. Just type it. Let me be sure we're following. I'll give us a few seconds for that. So let's see, fastest fingers, who gets it? So let me repeat myself. You share people, you recruit people into cohorts based on the presence or absence of the risk factor of interest. In a cohort study, you recruit people into cohorts or groups based on the presence or absence of the risk factor of interest. And what you do is you follow these people up in time to identify, is everybody copying from everybody? To identify the occurrence of the disease in the 2 groups. What that means is that cohort 1 will be smokers and cohort 2 will be non-smokers. Cohort 1, presence of the risk factor, smoking. Cohort 2, absence of the risk factor, non-smokers. Also, I have not called them control. I use my words very carefully. So don't call them control. If this is where confusion starts. There are 2 cohorts. I don't know whether you are someone you are from internal medicine, because that's what they do. Everything has control in internal medicine. Even when you are doing a cohort study, they say there are cases and control. We use the cases and control strictly for case control studies. And I will explain when we get there. We're not talking alcohol, cigarette smoking, and lung cancer. The alcohol people just copying themselves. They have not been in this class. So most of you are right so far. Cohort 1, smokers. Cohort 2, non-smokers. You are recruiting people based on the presence or absence of the risk factor. The risk factor. And then you follow them up. You observe. Remember, it's an observational study. You observe for outcomes of interest. You observe for outcomes of interest. In this case, the outcome of interest is lung cancer. So you observe for the development of lung cancer. You observe for the development of outcome of interest in both cohorts. In both cohorts. So by calculating the relative risk of the development of the outcome of interest between cohort 1 and cohort 2, you can identify, you can determine the relationship between the risk factor and the outcome of interest. Let me back up and say it again, because somebody say what? What did you say? by calculating the relative between one cohort and the other, between one group and the other. Relative risk is the probability of the occurrence of an event. That's a risk. The probability of the occurrence of an event. The relative risk is the probability of the occurrence of an event in one group divided by the probability of occurrence of the same event in another group. In other words, the probability of the development of lung cancer among cohort 1 divided by the probability of the development of lung cancer in cohort 2. So, if you started out with 100 persons, and I'm using 100 because that's very easy for the math. If you start out with 100 persons, you recruit 100 persons into cohort 1, smokers, 100 persons into cohort 2, non-smokers. You follow them up over a 20-year period, and over that 20 years, 30 people have developed lung cancer in the first cohort. Cohort 1, 30 people have developed lung cancer. What is the risk of developing lung cancer in this group? If you are using risk as the number of people who have lung cancer over the total population, what is the risk? That's that, and multiply it times 100, so I will make it a percentage. What is the risk of the development of lung cancer? Let's start from there. 100 people started out the study in cohort A, or cohort 1, and cohort 1 are smokers. At the end of 20 years, you have found out that 30 of them developed lung cancer. What is the risk of development of lung cancer in that group? Where the risk is calculated by the total number of persons who develop lung cancer over the total population at risk, which is 100, times 100%. What is the risk? Are we typing it? Let me check what we're saying. 30%. 30%. 30%, 30%, 30%. I agree with you. The risk is 30% among smokers. The risk is 30% among smokers. Come to non-smokers, cohort 2. I'm happy so many of you are following. Come to non-smokers, cohort 2. Out of 100 of them, in 20 years, 5 of the non-smokers, 5 of the persons in the non-smoking group developed lung cancer. What is the risk of lung cancer in the non-smoking cohort? 5%. Very easy, very easy. 30% smokers, 30% smoking cohort, 5% non-smoking cohort. What then is the relative risk? What then is the relative risk between the smoking group and the non-smoking group? How do you calculate that? The risk you have calculated in the smoking group divided by the risk you have calculated in the non-smoking group. Relative risk is 6. Not percentage, 6. Not percentage, 6. Because the percentage cancels this out. 30% over 5%. Percentage cancels out. Is an absolute number. It is 6. So relative risk is 6. And this is what we do with cohort studies. We calculate relative risk. So we say, this is the way we interpret that 6 or that relative risk. Persons who smoke are 6 times more likely to develop lung cancer compared to those who do not smoke. It's a compelling argument. Nobody needs to tell you again that lung cancer is a serious risk factor for smoking is a serious risk factor for lung cancer. You don't need any other prophet. You don't need any other thing to tell you. That you mean that it's not that people who don't smoke will not develop lung cancer, but that people who smoke are 6 times more likely to develop lung cancer compared to those who don't smoke. That is what cohort studies do. That's what cohort studies do. If I was talking to undergraduate students, I'll stop here. But because I'm talking to master's level students, let me explain one other thing about this whole prospective retrospective. I remember I said that you follow them up in time. And the assumption that it has given is that we follow them in time forward. In other words, you start at today. Today you recruit, then you are collecting, you are seeing these people, keeping tabs on them for 20 years. Every time one person gets lung cancer, you send him a sorry card, help him get treatment, but you're keeping the information until 20 years time. And I say, okay, let's collect. Which means that you are 20 years old, you are 20 years older or 21 years older, because it takes some years, months to publish the results. You are 21 years older when you publish your findings than you were when you started. That is a prospective cohort. Cohort can also be retrospective. Cohort can also be retrospective. Remember, you are still dealing with two groups selected based on the presence or absence of the risk factor of interest. So how can cohort be retrospective? You look for, if for example, it's a cancer clinic or a smokers clinic, or anywhere where smokers are gathered together. May not be easy to get, but fine. And then you go and you're able to get records from 20 years ago. And you're able to, based on records of 20 years ago, classify people into smokers and non-smokers. Today is 20 years after. How many of them over the 20-year period developed lung cancer in the smoking group and in the non-smoking group? Retrospective cohort. I'll stop there. Don't want to confuse you. But the point is that a cohort study is not just about following people up in time, forward or backward. A cohort is majorly about selecting people into one group or the other based on the presence or absence of the risk factor of interest. Then you do the follow-up. The follow-up may already have been done and you are just accessing the information. That will make it a retrospective cohort. Or you are actually doing the follow-up yourself to make it a prospective cohort. At the end of the day, what are you looking for? Relative risk. Relative risk tells you what's the association between the risk factor and the outcome of interest. Finish. An analytical cross-sectional study cannot calculate relative risk because there is no incidence happening. There is no, in something that is cross-sectional, you cannot see incidence. You can only calculate prevalence from a cross-sectional design. You can't calculate incidence. Incidence is a new case. For a new case to happen, time has passed. Time has passed, some observation has been taking place for there to be a new case of a disease. Once time cannot pass, you can't have, if you are picking the disease at that particular point in time, at that snapshot, it is prevalence, it is not incidence. You don't know whether it's a new case. All you know is that it's an existing case. It is there at a particular point in time. So what is the measure for cross-sectional study? If a relative risk is used for a case control, what do we do for a cross-sectional study? If a relative risk is used for a cohort, I beg your pardon, what do we do for a cross-sectional study? The same measure for a case control is the same measure we use for a cross-sectional study, and it is the odds ratio. The odds ratio. So let me explain a case control study. In a case control study, you are selecting cases and controls. So two groups. One group, you call them cases. The other group, you call them controls. That is why it is a case control, case versus control. One group, you call them cases. And we know what cases are: people that have the disease. We know what controls are: people that do not have the disease. So you are selecting people into two groups based on the presence or absence of disease. This is directly opposite from what a cohort does, selecting people into groups based on the presence or absence of risk factor. A case control selects people into groups based on the presence or absence of the disease. So using our same example of cigarette smoking and lung cancer, a case control will say cases lung cancer group 1, cases no lung cancer group 2. Lung cancer cases will be your cases. People that do not have lung cancer will be your controls, case control. Please do not ever use cases and control or control with a cohort study. It is cohort 1, cohort 2. It is in case control that you say you have cases and control. So if your design is not a case control study, if your design is a comparative or analytical cross-sectional, please don't say you are using controls. Anybody in internal medicine, forgive me, but this is the headache I usually have. Don't say you're using controls. Anyway, let me stop ranting my personal issues and move on. Case and control, case and control, case and control. All right. Now, what you do with a case control study is that you observe previous exposure to the risk factor. You observe. Remember, it's an observational study. You observe prior exposure to the risk factor. So example, in the example that we have used, remember, out of the smokers, we had 30 people who had lung cancer. Out of the non-smokers, we had 5 people who had lung cancer. Totally, we had 35 people that had lung cancer. Totally, 35 people have lung cancer in total, out of 200 persons. So the prevalence, the incidence of lung cancer is 35 over 200 times 100 for the entire population of everybody. Now, if you were to do a case control study, and you were to, which means that you recruit based on cases and controls, 35 persons will be in your cases, while 165, I hope my math is correct, 165 will be your controls. I'm just telling you loosely, they don't have lung cancer. So assuming we're going to use this and throw it up and make it a case control study, the number of people who have lung cancer will be in your group, one group. But the way we usually do it is, for everybody who is a case, we try to find a similar person. Similarity is in age and sex, who does not have the disease. So for each one of those 35 persons who have lung cancer, we try to find 35 persons who are matched most of the time by age and sex, because age and sex affects the most diseases, prevalence, incidence of most diseases. So you want to control for that. So most of the time, for every person who is a case, you try to look for an age and sex matched control. So that you have like equal numbers as cases and controls. So let's assume, for the purpose of this, is that we have 100 persons who have lung cancer and 100 persons who don't have lung cancer, matched age and sex, 100 persons in as cases and 100 persons as controls. All right. So for the ease of mathematics, now you have checked these people's history, either by asking them questions about their history, checking their folders if they were coming to a health facility. You've asked them questions like, have you ever smoked before? When did you first, if they say yes, when did you first start smoking? How often do you smoke? Did you quit smoking at any time? Are you currently smoking? And all those questions are just geared at understanding their exposure to the risk factor, which is smoking. Out of 100 people who have lung cancer, you discover that 40 of them were active smokers. They've smoked for at least 20 years. 40 of them. While in the other group of the 100 people, you find out that 5 of them, I like this word, this number 5, 5 of them have smoked. 5 of them. So, what measure are you calculating? Measure of the disease occurrence. Are you calculating in this scenario? It is odds. The probability you are calculating is odds. The probability So we don't use risk. We use odds now because you are not dealing with new occurrence. You are dealing with existing occurrence. What is, I don't know whether you did proportion, risk, and odds. The formula for risk is the total number of persons who have the outcome, what you are interested in, over the total number of persons at risk, that's total population times 100. Odds is the number of persons who have divided by number of persons who do not have. That is odds. The odds of winning the lottery. The odds of winning the lottery is the number of persons who have the lucky number over the total number of persons who do not have the lucky number. That's odds. Odds of passing the exam. The total number of people who pass the exam divided by the total number who don't pass the exam. Odds. It's different from risk. Risk, if there's anything like that, of winning the lottery, is the total number of people who have the winning ticket, the winning number, over the total number of people who played the lottery. You see the difference? The denominator is the difference. So, as I've defined odds for you now, help me calculate odds of lung cancer among odds of persons who smoked having lung cancer. How do you calculate it? Let's do that together. It is those who have lung cancer, those who smoked, which is 40, divided by those who did not smoke, out of the people that have lung cancer. So 40 over 60 gives you what? Times 100. Quickly do it. That's 2 over 3. That's about 60-something percent. Let somebody can do, please do for me. Let me show you're following. Yeah. So it's about, yeah, so if you do percentage, about 66, it's about 66.6%, something like that. I agree with the people that say 66.6, 66.7. Yes, I agree with you. So that's the odds. That's the odds of lung cancer. Okay, so let's do the same. Let's do the same for odds in the other group. Remember, that's 5 divided by 95, isn't it? 5 people ended up being people who smoked. 95 were not smokers. So what's the odds? 5 divided by 95 times 100. And then let's calculate the odds ratio. Odds in the cases divided by odds in the control. That's odds ratio. Odds is 5.23 or 5.26%. What is that one? People who are saying 5.26, what are you calculating? Explain to me. Are we doing the 5 divided by 95? Is that what you're doing? Okay, yes. I agree with you. That's what you're doing. 5 divided by 95. Beautiful. So let's do 66.7 divided by 5.26. 12.6. 12.66. Let's say just say 1 decimal point. 12.68 was 12.7. Yeah. So 12.68, 12.7. Fine, correct. 12.7. 12.7. So how do you interpret this? Though among those who have lung cancer, there was a 12.7 times greater odds of them being smokers than those who did not have lung cancer. Among persons with lung cancer, there was a 12.7 times greater odds of them being smokers than those who do not have lung cancer. Remember, odds starts from disease of interest and uses that to interpret the risk. All right, it's been interesting so far. So if you notice the directionality of measurement for case control is back in time. But interesting that practically you may be meeting those people in your clinic, and you have like appointments every week. You meet 5 of them. Every week you meet 5 of them. Every week you meet 5 of them. You interview them about their past. If you look at how often you meet them, you meet 5 every. You say this is cross-sectional. It's not cross-sectional. You are interviewing them about their past. It is retrospective. So, but you see, these things can confuse, and it doesn't help you understand the method, what is really going on, what's the objective of the research design. So I don't use that to explain, but I always find the opportunity to explain that if you're collecting information going forward, or you're collecting information retrospectively, it's all longitudinal, as opposed to you're collecting information at a particular point in time. It is cross-sectional. So odds ratio is the same thing. You do the odds in the group, in one group, divide by the odds in the comparison group, and for cross-sectional. So we calculate odds ratio for cross-sectional and odds ratio for case control, and we calculate relative risk for cohorts. All right, my mouth is officially paining me now. Let me take a few questions on the chat. Then we'll go to experimental, we'll call it a day. I think if I take another 20 minutes max of your time, we should be able to close. Sorry for being, I really don't want to come and teach you guys tomorrow, so I'm trying to finish today. I hope that's fine. All right, let's see the questions. I hope I can take them very easy. Okay. Manny, go and eat. Oh, nobody is stopping you. Just leave the class and go and eat. This food is very important. All right, odds ratio. Let's explain odds ratio. So there are different ways you can calculate. Gloria, send the question. Send the question to the chat group, please. There are no slides to be seen changing now. All I'm showing is one diagram. That's all I've been showing for the past 1 hour plus. So anybody that thinks slides will be changing, I'm very sorry. I will send the slides to you going on. Right. So there are different ways to calculate the frequency of occurrence of a disease. So when you're talking about incidence can be calculated as, incidence can be presented in whole numbers. 20 people, 20 new cases of malaria, that is incidence. It can be presented as a proportion. And when it's presented as a proportion, it's either presented as risk or odds. Risk is the number of people who have the disease, new cases of the disease, over the total population. The assumption is that the total population are the people at risk, multiplied by 100. That is risk. Odds, total number of people who have the disease over total number of people who do not have the disease. Odds. Those who have divided by those who do not have. Those who got it divided by those who did not get it. That's odds. Now, if you do the odds ratio in your case control study, the odds of those who are lung cancer patients having smoked, the odds that lung cancer patients were smokers, we said it was 66.7%. That's the odds. And you see it's high. The odds that non-lung cancer patients were smokers, we saw it as 5.26%. What's the odds ratio? Odds in cases divided by odds in controls. That's why we had 66.7 divided by 5.26, and we said it was 12.7 to 1 decimal place. And what is the interpretation? Persons who cases cases of lung cancer had a 12.7 times greater odds of being smokers than those who did not have lung cancer. 12.7 times greater odds of being smokers than those who did not have lung cancer. Okay, thank you. Now, let me mention one thing before I make progress. There are times when you are not dealing with a quote and unquote risk factor. You know, a risk factor increases the probability of you having a disease. You are rather dealing with a protective factor that decreases your probability of having a disease. Typical example, exercise and osteoporosis. So a study was done, a case control study was done. A group of women who exercise regularly were followed up to see the development of osteoporosis after 10 years. So these women, they started them at about between when they were 50 and 60. They followed them up for about 10 years to see the incidence of osteoporosis. One cohort were women who were fanatical about physical exercise. The other cohort were women who did not do any physical exercise. They looked at them again in 10 years to see the prevalence or the incidence of osteoporosis. 100 again, I'm using 100 simply because it is easy to calculate the math. Don't expect that if I bring an exam question, I will use 100, though, that will be too easy for master's class. Anyway, so 100, these 100 were exercise women, these 100 were non-exercise women. You move them forward in 10 years' time, you found out that among the exercise women, let's say 6 of them had developed osteoporosis. Among the unexercised women, 60 of them had developed osteoporosis. Among the exercised women, 6 had developed osteoporosis. Among the non-exercised women, 60 had developed osteoporosis. What is the relative risk of osteoporosis? Okay. 0.1, 0.1, 0.1. Jumbo, you're one of my best students so far. Yes? Shoma, thank you. 0.1, 0.1. Yes, otherwise known as 10%. 0.1, 10%. Yes, yes. Because the principle is the same. Risk in exposed divided by risk in unexposed. Risk in those who have. So what does it mean that the risk is 10% or 0.1? Once the risk is less than 1, if the risk is 1, there's no difference between one group and the other. You know, 1 means it's the same, isn't it? There's no difference between one group and the other. If it is more than 1, it means that one group has a 2 times, 3 times, 4.5 times greater risk than the other group. But if it is less than 1, it means there's a protection. It is a protective, what they are exposed to protects them against the outcome of interest. And how do you know the protection? You do 1 minus relative risk. 1 minus relative risk. So if relative is 0.1, 1 minus 0.1 is 0.9, otherwise called 90%. So those who exercise have a 90% lesser chance of developing, lower probability, 90% lower probability of developing osteoporosis than those who don't exercise. 90% lower chance, 6 over 60 times 90% lower chance of developing osteoporosis. You must subtract it from 1 for you to be able to interpret it properly, because it's a protective factor. Therefore, we can conclude that exercise protects women against osteoporosis. All right, let me run away from there. Experimental, very fast. Experimental, there's an intervention, there's a manipulation, there's something you are putting in, there's something you are adding to one group and not adding to the other group. So again, experimental, just like analytical, you need groups. You need groups. You cannot just do on one group. But there is a type of experimental study in which you have only one group. But even then, you take measurements before and after. I will explain when we get there. So experimental. So two broad are randomized control and non-randomized control trials. That's the two broad categories. So a randomized control trial is a true experiment. Of course, an experiment means you are bringing in something, and some group will have it, some other group. So for example, you want to see the effect, and you do experimental designs to measure the effect, to measure how much change will happen to the outcome if you bring in a factor. How much change? So you actually literally measuring effect. So you don't really you don't measure just relative risk anymore, because you're not talking about probability. In experimental design, you have to start talking about effect. So when you do your research and you use words in your title like the effect of exclusive breastfeeding on child growth indices, and I look at it, I will go quickly and see, is it an experimental design? If I see descriptive cross-section, I will come and put a big red mark around effect. Be careful about the use of the word effect, because effect is, cause and effect. You are making something happen. Action and reaction are equal and opposite. Cause and effect, you are making something happen. So if I see you're not making anything happen, you're merely observing, I'll tell you, no, wrong design, wrong title, doesn't go with the design. So randomized control trial, non-randomized control trial. A randomized control trial is a true experiment, while a non-randomized control trial is a quasi. Quasi is pretend, quasi experiment, QUASI. A true experiment has certain features. One, there is a comparison group, a true comparison group. Two, there is randomization. And I will explain what randomization is, because people mix it up with randomly collect the sample, with simple random sampling, and so on and so forth. They're not exactly the same thing. And three, there must be an intervention. So there's an experiment, an intervention. That intervention must have two or more groups that you're working in, and persons, I'm explaining randomization now, persons are assigned to the intervention or the control group by chance. Randomization, it's a method by which persons are assigned to the intervention group or the control group by chance, not by the decision of the investigator, not by the decision of the study participant, but strictly by chance. In other words, probability determines whether someone gets into the intervention group, the experiment group, or gets into the control group. Probability decides it. So when we say probability decides it, there's something you have to do. For example, if you do a simple ballot in which there is yes, no, or in which there is 1, 2, 3, 4, 5 to 10, and you have predetermined that 1, 3, 5, 8, 10 are in the intervention group, while the other numbers are in the control group. The person picks, is what the person picks that the person gets. The person doesn't even know that what is picking is intervention, what is picking is control. You don't do your intervention, your control. No, they are not supposed to even know if it's a true experiment. And that is randomization. That is randomization. So a true experiment. Many true experiments have a further characteristic of it, which is called blinding. Blinding means the study participant does not know functionally which group he or she is in. Blinding means study participants, and sometimes even the research team, do not know which group the study participant is in. Here we have single blinding, and we also can have double blinding. Single blinding, the study participant does not, only the study participant don't, every other person knows that this man is in intervention group, this other one is a control group. For example, if you are doing a drug trials often have to follow randomized controlled trials with blinding, single blinding at least, sometimes double blinding. You have a pill, a drug, you want to know the effectiveness, the efficacy of that drug, and the effect on the outcome, whether maybe it's a pain medication, you want to know by how much it reduces pain and all of that. And then you have what we call a placebo, a pill that has absolutely no active ingredient in it, that is shaped and looks exactly the same. So as they are swallowing, they don't know what they are swallowing. That's blind. They don't know whether they are swallowing the active ingredient or whether they are swallowing chalk. That's blinding, single blinding. Sometimes the research assistants, somebody has to know. So maybe the person who designed the research knows. But sometimes the research assistants that are giving the pill and taking the data to say, what is your pain this morning on a scale of 1 to 10? They don't know, and that's double blinding. That's double blinding. But somebody is somewhere there who knows. And the reason for blinding is that you do not want knowledge of the group the person is in to influence the outcome. Sometimes if somebody knows that I'm taking the drug that is effective, the mind is very powerful. I'm taking the drug that is effective. Even if it's really effective or not, this is the experimental drug. They will be telling you by pain 0. Meanwhile, the pain should be like 4 or 5. They'll tell you, pain, I'm not feeling any pain. Which kind of pain? How? When? Just because they know. But if they are blind to it, they can give you honest responses without really knowing. If the research team, the people who are in the day-to-day running of the research, if they know, they want the research to work. So they may be paying more attention to the people that have the active ingredients, asking them very well, are you sure? Measure the pain. Okay, is it not like this? Are you sure it's not like that? Making suggestions, contaminating your study. So sometimes you don't want them to know either. But we know that blinding in some situations is completely impossible. If it is a surgical intervention, will they not know if it is midline or umbilical or if it is phanestil? Will you blind to that? You may not be able to blind to that. So sometimes there's no option. You cannot blind. But at all times, if it's an RCT, try to achieve the randomization. Don't be the one to choose who gets intervention, who gets it. Let probability, let balloting, let chance do that for you. So anything apart from that is a non-randomized control trial. For quasi-experimental, they may not be randomization because you cannot do randomization. They may not be a control group. Sometimes you may not have a control group. So you're collecting measurement before the intervention. You do the intervention, you collect measurement after the intervention. That is a before and after design. So the two groups are the people before and the people after. But it's the same people, the same people. So you can see that really you have two groups, just that the two groups are the same person multiplied, same set of people multiplied in two directions. All right. So I think I've explained all of that now. I will take questions if you have any for experimental design, and we'll call it a day. So please, let me have your questions. If you have questions, type into the chat box. I'll just wait for 1 or 2 minutes. No questions, I'll tell you thank you very much and bye-bye. So I'll send you the slides. Send you all the slides. I'll send you the, I'm sure Daniel will be able to allow you to have access to the videos. By the way, I've uploaded all the videos for all the other lectures. If you've not already gotten it, Layers with Daniel. all the lectures I've given so far up until yesterday, all the lectures of yesterday, I've uploaded all my video slides. People who complained it wasn't clear, blah, 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 blah. You'll be able to see it. Show you can decide to go watch it again and again and all of that. I think I've taken, I'll send you a couple of slides immediately, maybe this night or very early tomorrow morning, for the lectures I've taken today. And I see how the videos also, I believe the videos can also get to you. I did some of those videos and recorded them on my system myself, so I'll send to you. Some went to the cloud, and I would. So someone is asking, is it the end? It's not the end, though. Alaliba will talk to you about makeup lectures, which should happen tomorrow. I don't know whether I may have one lecture with you tomorrow. Let me just go back and look at what we haven't covered. I may have one lecture with you tomorrow. Dr. Ojule may also have one lecture with you tomorrow, but I would allow your class rep to sort out all those matters. But I won't. If I'm with you tomorrow, I'll spend more than 1 hour, and I'll be done. Then you can go and prepare for your exams. All right.
How are you? What's the name?
Thank you, man. Thank you very much.
All right.
Oh,
Thank
we
you.
appreciate. We really appreciate. Wonderful lecture.
This is excellent.
This is lecture. Lecture indeed. This is powerful lecture.
Oh my, thank you.
Powerful.
This is another prof best.
This is powerful.
No, this one is more than prof best, I bet.
No, you can't beat prof best, please.